Welcome to this advanced continuing education course on total shoulder arthroplasty and evidence-based update. Over the next several hours, we'll explore the dramatic evolution that shoulder arthroplasty has undergone over the past decade, examining expanding indications, refined surgical techniques, and evidence-based rehabilitation protocols that directly influence patient outcomes. Total shoulder arthroplasty, including both anatomic and reverse approaches, now represents the gold standard intervention for glenohumeral pathology. However, optimal patient selection, surgical decision-making, and postoperative rehabilitation remain areas of active clinical investigation and debate. As rehabilitation professionals, including physical therapists, occupational therapists, nurses, and allied health practitioners, you play a critical role in the perioperative continuum from preoperative assessment and patient education through long-term functional restoration and complication prevention. This course will provide you with a comprehensive, evidence-based update on total shoulder arthroplasty rehabilitation, emphasizing contemporary clinical reasoning, protocol individualization, and management of complex patient populations. You'll examine the nuanced decision-making processes that differentiate anatomic from reverse arthroplasty indications, analyze phased rehabilitation protocols with quantitative progression criteria, and develop strategies for managing high-risk populations including patients with diabetes, prior shoulder surgery, rotator cuff pathology, and multiple comorbidities. By the end of this course, you'll be able to differentiate between anatomic and reverse total shoulder arthroplasty indications based on patient-specific factors including rotator cuff integrity, glenoid morphology, age, functional demands, and comorbidity profiles. You'll analyze the biomechanical principles underlying glenoid lateralization, humeral lateralization, and tendon transfer techniques and their implications for postoperative rehabilitation progression and functional outcomes. You'll evaluate evidence-based rehabilitation protocols for anatomic and reverse total shoulder arthroplasty, including phase-specific criteria for progression, range of motion targets, and strengthening guidelines according to current American Society of Shoulder and Elbow Therapists consensus standards. Additionally, you'll classify high-risk patient subgroups and determine appropriate protocol modifications to optimize safety and functional recovery. You'll assess early warning signs of postoperative complications and apply evidence-based management strategies for timely intervention. You'll compare functional outcomes, complication profiles, and return to activity rates between anatomic and reverse total shoulder arthroplasty in diverse patient populations. Finally, you'll apply clinical reasoning frameworks to complex case presentations, integrating surgical approach, patient comorbidities, and evidence-based rehabilitation principles to develop individualized treatment plans. Let's begin with Module 1, Surgical Indications and Patient Selection for Total Shoulder Arthroplasty. The selection between anatomic total shoulder arthroplasty and reverse total shoulder arthroplasty represents one of the most consequential clinical decisions in contemporary shoulder surgery, with profound implications for postoperative rehabilitation, functional recovery, and long-term patient satisfaction. While both procedures reliably reduce pain and improve function in appropriately selected patients, emerging evidence from large-scale registry studies and meta-analyses published between 2022 and 2025 has refined our understanding of optimal indications, contraindications, and comparative outcomes across diverse patient populations. Let's start by examining anatomic total shoulder arthroplasty. This approach remains the preferred surgical intervention for patients with primary glenohumeral osteoarthritis who possess an intact rotator cuff and adequate glenoid bone stock. The procedure replicates native shoulder anatomy by replacing the humeral head and glenoid with prosthetic components that maintain normal ball and socket articulation, thereby preserving physiologic biomechanics and relying on rotator cuff integrity for joint stability and function. Contemporary evidence demonstrates that anatomic arthroplasty yields superior outcomes in external and internal rotation compared to reverse arthroplasty, with higher rates of patients achieving what has been termed a new normal shoulder. This is defined as near-complete restoration of function and the ability to perform high-demand activities without limitation. In a 2025 comparative study, patients who perceived their shoulder as normal after surgery were significantly more likely to have undergone anatomic rather than reverse arthroplasty, and these patients demonstrated superior return to work and sport participation. The anatomic approach is particularly advantageous for younger, active patients with high functional demands who seek to maintain rotational motion and return to overhead activities or physically demanding occupations. Evidence from 2022 through 2025 confirms that anatomic arthroplasty provides more predictable restoration of external rotation and internal rotation, with mean improvements exceeding those achieved with reverse prostheses. However, the success of anatomic arthroplasty is contingent upon strict patient selection criteria. Absolute contraindications include irreparable rotator cuff tears, significant rotator cuff dysfunction, severe glenoid bone loss that precludes stable component fixation, and active infection. Patients with borderline rotator cuff integrity, subclinical cuff degeneration, or risk factors for postoperative cuff failure such as advanced age, poor tissue quality, or prior failed cuff repair experience higher rates of complications and conversion to reverse arthroplasty when treated with anatomic prostheses. Now let's turn our attention to reverse total shoulder arthroplasty and its expanding indications. Reverse total shoulder arthroplasty was originally designed to address rotator cuff tear arthropathy and massive irreparable rotator cuff tears, conditions in which anatomic arthroplasty consistently fails due to superior humeral migration and eccentric glenoid loading. The reverse design inverts the normal ball and socket configuration, placing a glenosphere on the scapula and a concave polyethylene cup on the humerus, thereby medializing the center of rotation and recruiting the deltoid muscle to compensate for deficient rotator cuff function. Over the past decade, indications for reverse arthroplasty have expanded dramatically beyond rotator cuff pathology to include elderly patients with primary osteoarthritis and an intact rotator cuff, complex proximal humerus fractures, failed prior arthroplasty, and cases of severe glenoid bone loss or eccentric wear. The most compelling contemporary evidence for expanded indications comes from large population-based cohort studies and meta-analyses demonstrating that reverse arthroplasty provides comparable or superior clinical outcomes to anatomic arthroplasty in patients aged 75 years and older with primary osteoarthritis, even when the rotator cuff is intact. A 2024 population-based study using data from the National Joint Registry of England analyzed over 20,000 shoulder arthroplasties and found that reverse arthroplasty was associated with lower rates of revision surgery and similar patient-reported outcome measures compared to anatomic arthroplasty in older adults with osteoarthritis. Similarly, a 2025 meta-analysis of 14 comparative studies found that reverse arthroplasty demonstrated significantly lower rates of complications and reoperations compared to anatomic arthroplasty in patients with intact rotator cuffs, albeit at the expense of reduced external rotation. Specific clinical scenarios in which reverse arthroplasty may be preferred over anatomic arthroplasty include patients with limited preoperative forward elevation, less than 90 to 100 degrees, as these individuals achieve faster and more predictable improvements in overhead range of motion with reverse prostheses. Evidence from 2023 and 2024 demonstrates that patients with restricted preoperative elevation who undergo reverse arthroplasty achieve similar final functional outcomes to those treated with anatomic arthroplasty, but with accelerated recovery timelines and lower revision rates. Additionally, reverse arthroplasty is increasingly favored in elderly patients due to concerns about occult rotator cuff degeneration, lower demands for rotational motion, and reduced risk of subscapularis failure or glenoid loosening complications that disproportionately affect anatomic arthroplasty in this population. Let's now examine the comparative outcomes and clinical decision-making between these two approaches. Direct comparison of anatomic and reverse arthroplasty outcomes reveals important trade-offs that must be weighed in clinical decision-making. Both procedures provide substantial and durable pain relief, with no clinically significant differences in pain scores at mid to long-term follow-up in appropriately selected patients. Functional improvement, as measured by validated patient-reported outcome measures including the American Shoulder and Elbow Surgeon Score, Simple Shoulder Test, and University of California Los Angeles Score, is comparable between the two approaches in elderly patients with intact rotator cuffs, with some studies demonstrating a slight advantage for reverse arthroplasty. However, anatomic arthroplasty consistently outperforms reverse arthroplasty in restoration of external rotation and internal rotation, with differences of 15 to 25 degrees in external rotation representing a meaningful functional distinction for younger, active individuals. Return to high-demand activities, including work and sport, is more reliably achieved after anatomic arthroplasty in patients with intact rotator cuffs. A 2023 study found that 89% of patients undergoing anatomic arthroplasty returned to their desired sports activities, compared to 79% of reverse arthroplasty patients, and that anatomic arthroplasty was associated with participation in a greater number of sports. The rate of achieving a new normal shoulder, the highest level of functional recovery, is significantly higher after anatomic arthroplasty at 47%, compared to reverse arthroplasty at 24% in patients with intact rotator cuffs. These findings underscore the importance of preserving anatomic reconstruction in younger, active patients who prioritize maximal rotational motion and high-level function. Conversely, reverse arthroplasty offers important advantages in terms of surgical simplicity, lower revision rates, and more predictable outcomes in the setting of compromised soft tissues or bone quality. Complication and revision rates are consistently lower for reverse compared to anatomic arthroplasty in elderly patients and those with poor preoperative elevation, with some studies reporting revision rates as low as 2 to 3% for reverse arthroplasty compared to 5 to 7% for anatomic arthroplasty at 5-year follow-up. The most common complications following anatomic arthroplasty, rotator cuff failure, subscapularis insufficiency, and aseptic glenoid loosening, are essentially eliminated with reverse arthroplasty due to the fundamentally different biomechanical design. However, reverse arthroplasty carries its own complication profile, including scapular notching, acromion or scapular spine fracture, and prosthetic instability, although these occur at relatively low rates and do not typically compromise overall functional outcomes. Beyond rotator cuff integrity and glenoid morphology, several patient-specific factors influence surgical decision-making and expected outcomes. Advanced age, while not an absolute contraindication to anatomic arthroplasty, is associated with higher rates of postoperative rotator cuff failure and conversion to reverse arthroplasty. Current evidence supports consideration of reverse arthroplasty in patients aged 75 years and older, even with intact rotator cuffs, given comparable functional outcomes and lower revision rates compared to anatomic reconstruction. Comorbidities including diabetes, obesity, inflammatory arthritis, and prior shoulder surgery increase the risk of complications and may influence implant selection. While these conditions do not represent absolute contraindications to either procedure, they necessitate careful preoperative counseling and individualized rehabilitation planning. Functional demands and patient expectations must also be incorporated into surgical decision-making, with anatomic arthroplasty favored for younger patients seeking maximal function and reverse arthroplasty appropriate for older, lower-demand individuals prioritizing pain relief and basic overhead function. Now, let's discuss the implications for rehabilitation planning. The choice between anatomic and reverse arthroplasty has direct implications for postoperative rehabilitation protocols. Anatomic arthroplasty requires strict protection of the subscapularis repair, prolonged immobilization for 4 to 6 weeks, and gradual progression through passive, active-assisted, and active range of motion before initiating strengthening exercises. External rotation and internal rotation precautions are critical to prevent subscapularis failure, and patients must be counseled regarding realistic timelines for return to high-level activities, typically 4 to 6 months. In contrast, reverse arthroplasty protocols are increasingly accelerated, with immediate mobilization and minimal immobilization supported by contemporary evidence, particularly when the subscapularis is not repaired. The absence of rotator cuff-dependent stability in reverse arthroplasty allows for earlier active motion and functional training, although precautions to prevent dislocation, particularly avoiding combined adduction, internal rotation, and extension, remain important. Understanding the indications, contraindications, and comparative outcomes of anatomic and reverse total shoulder arthroplasty is essential for rehabilitation professionals to deliver evidence-informed care, set appropriate patient expectations, and design individualized protocols that optimize functional recovery while minimizing complications. Let's move now to Module 2, Evidence-Based Rehabilitation Protocols for Anatomic Total Shoulder Arthroplasty. Postoperative rehabilitation following anatomic total shoulder arthroplasty is structured around 3 distinct phases that correspond to tissue healing timelines, surgical precautions, and progressive restoration of shoulder function. The American Society of Shoulder and Elbow Therapists published a consensus statement in 2020 that remains the foundational framework for anatomic arthroplasty rehabilitation, emphasizing protection of the subscapularis repair, gradual progression of range of motion, and evidence-based criteria for advancement through rehabilitation phases. Let's begin with Phase 1, protection and early mobilization, from postoperative day 1 to week 4 through 6. The initial rehabilitation phase following anatomic total shoulder arthroplasty is dominated by tissue protection, pain management, and controlled passive mobilization to prevent postoperative stiffness while safeguarding the subscapularis repair and capsular healing. The subscapularis tendon is typically tenotomized or peeled from the lesser tuberosity during the surgical approach and meticulously repaired at the conclusion of the procedure. Failure of this repair is one of the most common complications following anatomic arthroplasty and results in persistent pain, anterior instability, and compromised functional outcomes. Consequently, strict precautions regarding external rotation and active shoulder elevation are enforced throughout this initial phase. Patients are instructed to wear a sling continuously except for hygiene and prescribed exercises, with the sling typically positioned in neutral rotation or slight internal rotation. Emerging evidence from the American Physical Therapy Association's 2023 Clinical Practice Guidelines suggests that immobilization in a neutral rotation sling may be associated with reduced night pain and improved external rotation recovery compared to traditional internal rotation sling positioning, and should be considered as a management option for patients undergoing anatomic arthroplasty. The duration of sling immobilization typically ranges from 4 to 6 weeks, with variation based on surgeon preference, quality of subscapularis tissue at the time of repair, and patient-specific factors such as tissue quality and compliance. Passive range of motion exercises are initiated on postoperative day 1 and progressed gradually within specific quantitative limits. The American Society of Shoulder and Elbow Therapists consensus recommends passive elevation in the scapular plane to a maximum of 120 degrees and passive external rotation with the arm at the side to 30 degrees, unless otherwise specified by the operating surgeon based on intraoperative findings. These limits are designed to protect the subscapularis repair while preventing adhesive capsulitis, a complication that occurred more frequently in earlier eras when prolonged immobilization was routine. Active shoulder elevation is strictly contraindicated during Phase 1, as is placing the hand behind the back, which is functional internal rotation, external rotation at 90 degrees of abduction, and any weight-bearing activities involving the operative upper extremity. Exercises during this initial phase focus on maintaining mobility of the elbow, wrist, and hand, passive shoulder elevation using table slides, rope and pulley systems, or supine well-arm-assisted elevation, passive external rotation within prescribed limits, and gentle scapular retraction exercises to maintain parascapular muscle activation. Pendulum exercises, long advocated for early shoulder rehabilitation, should be performed with caution, as electromyographic studies demonstrate that these exercises can elicit significant deltoid and rotator cuff activity that may stress healing tissues. Pain management is achieved through multimodal analgesia, ice application, and patient education regarding activity modification. Non-impact aerobic conditioning such as walking or stationary cycling, once the incision is healed and cleared by the surgeon, is encouraged to maintain cardiovascular fitness and promote systemic recovery. Progression from Phase 1 to Phase 2 requires satisfaction of specific clinical criteria, including pain levels consistently below 3 out of 10 with passive range of motion exercises, a well-healed surgical incision without signs of infection or dehiscence, and explicit clearance from the operating surgeon after radiographic assessment to rule out implant loosening, fracture, or other complications. Radiographic evaluation typically occurs at the 4 to 6 week postoperative visit and includes anteroposterior, axillary, and scapular Y views to assess component position, bone implant interface, and humeral head alignment relative to the glenoid. Now let's move to Phase 2, active motion and dynamic stability, from week 4 through 6 to week 12. Phase 2 represents a critical transition from passive mobilization to active shoulder control, with emphasis on restoring active range of motion that matches the passive mobility achieved in Phase 1, developing dynamic glenohumeral stability through coordinated muscle activation, and establishing the foundation for functional use of the upper extremity in activities of daily living. The sling is discontinued at the beginning of Phase 2, typically at 4 to 6 weeks postoperatively, although some surgeons prefer a more gradual weaning process with intermittent sling use during the first week of active mobilization. Active range of motion exercises are introduced systematically, beginning with active assisted elevation and progressing to unassisted active elevation, external rotation, and internal rotation. External rotation at 90 degrees of abduction in the scapular plane is permitted up to 60 degrees during this phase, representing a carefully calibrated progression that balances subscapularis protection with functional restoration. Gentle functional internal rotation, placing the hand behind the back to reach the lumbar spine, is initiated cautiously, as this motion places significant tensile load on the subscapularis repair and should be progressed only as tolerated and with explicit surgeon approval. Scapular muscle activation is emphasized during phase 2 to establish dynamic stability and prevent compensatory movement patterns that can compromise long-term function. Active scapular retraction, protraction, elevation, and depression exercises are performed against gravity, and parascapular strengthening begins with isometric contractions progressing to low-resistance isotonic exercises. The deltoid and rotator cuff muscles are activated through gravity-minimized exercises initially, with progression to against gravity positions as strength and motor control improve. However, resistance training remains restricted to below shoulder level and anterior to the frontal plane throughout phase 2. And closed chain exercises such as planks or push-up variations are contraindicated until phase 3. Aerobic conditioning is expanded during phase 2 to include elliptical training without upper extremity resistance, lower body weight training, and continued walking or cycling programs. Functional training for activities of daily living is integrated progressively, with emphasis on using the operated arm for light tasks such as feeding, grooming, and computer work, while avoiding lifting objects heavier than 1 to 2 pounds and refraining from pushing, pulling, or jerking motions that could jeopardize healing tissues. Advancement from phase 2 to phase 3 requires achievement of active range of motion against gravity that approximates passive range of motion, absence of pain with active motion and functional activities, and the patient's readiness for higher-level functional demands related to work or recreational activities. Quantitative benchmarks for passive range of motion that are associated with maximal patient-reported outcome improvement have been identified in a 2025 study. Abduction greater than 130 degrees, forward elevation greater than 162 degrees, external rotation greater than 52 degrees, and internal rotation to the L1 vertebral level. Achieving these thresholds is associated with minimal additional improvement in patient-reported outcomes beyond these values, suggesting that rehabilitation goals should be individualized based on functional requirements rather than pursuing maximal motion in all patients. Let's now discuss Phase 3, strengthening and return to activity from week 12 and beyond. Phase 3 focuses on progressive resistance training to restore strength, power, and endurance of the shoulder musculature, with the ultimate goal of enabling patients to return to desired activities including work, recreation, and sport at an appropriate level of intensity and demand. Resistance exercises are introduced at 12 weeks postoperatively, emphasizing low load and high repetition to promote muscular endurance and minimize risk of tendon overload. Strengthening exercises target the deltoid, rotator cuff, and parascapular muscles, with particular attention to the posterior rotator cuff and scapular stabilizers to counterbalance the subscapularis repair and promote balanced force couples around the glenohumeral joint. Weight training is permitted during Phase 3, but with important caveats. All resistance exercises should be performed below shoulder level and anterior to the frontal plane to minimize stress on the subscapularis and anterior capsule, and patients should avoid impact loading activities such as sledgehammer use, wood chopping, or bench pressing, as these activities generate high compressive and shear forces that may compromise the long-term integrity of the prosthesis or soft tissue repairs. Closed chain exercises, including planks, modified push-ups, and yoga poses that involve upper extremity weight bearing, are permitted during Phase 3, as the subscapularis repair is considered sufficiently healed to tolerate these loads by 12 weeks postoperatively. Return to sport and recreational activities is approached systematically, with consideration of both the physiological healing timeline and the specific demands of the desired activity. Advanced upper extremity sports such as golf and tennis may be initiated at 4 months postoperatively, with full unrestricted participation typically delayed until 6 months to allow for complete tissue maturation and strength development. Swimming, particularly freestyle and backstroke, is generally permitted at 4 to 5 months, while contact sports or high-impact activities require careful individualized assessment and surgeon approval. Patients should be counseled that lifelong maintenance of shoulder flexibility and strength through regular stretching and strengthening exercises is recommended to preserve function and prevent secondary complications such as adhesive capsulitis or rotator cuff degeneration. Now let's examine the contemporary evidence on early versus delayed rehabilitation and subscapularis-specific protocols. A fundamental question in anatomic arthroplasty rehabilitation is whether early aggressive mobilization provides superior outcomes compared to more conservative delayed protocols. A 2022 systematic review evaluating this question found that early rehabilitation, initiation of passive range of motion within the first postoperative week, versus delayed rehabilitation, immobilization for 3 to 4 weeks before initiating motion, does not result in significant differences in pain, function, health-related quality of life, or healing complications at 12-month follow-up. Early rehabilitation may provide short-term benefits in pain reduction and functional recovery during the initial postoperative period, but these advantages dissipate by 3 to 6 months, and long-term outcomes are equivalent between approaches. These findings support the American Society of Shoulder and Elbow Therapists' consensus recommendation that passive range of motion be initiated early, on postoperative day 1, but within strict quantitative limits, rather than advocating for either complete immobilization or unrestricted motion. The American Physical Therapy Association's 2023 guideline goes further, noting that delaying the initiation of shoulder range of motion exercises for up to 4 weeks postoperatively does not negatively impact patient-reported outcomes and may be appropriate in select patients with compromised tissue quality, complex surgical procedures, or concerns about healing. This evidence provides reassurance that rehabilitation professionals can individualize the timing and intensity of early mobilization based on patient-specific factors without compromising long-term functional outcomes. Given the critical importance of subscapularis integrity to anatomic arthroplasty outcomes, significant interest has focused on whether augmenting standard rehabilitation protocols with subscapularis-specific strengthening exercises improves functional recovery and reduces the risk of subscapularis failure. A 2023 prospective, double-blinded, randomized controlled trial directly evaluated this question by comparing standard American Society of Shoulder and Elbow Therapists-based rehabilitation to an enhanced protocol incorporating early subscapularis-specific internal rotation strengthening beginning at 6 weeks postoperatively. The study found no significant differences between groups in subscapularis strength, patient-reported outcomes, or complications at 3, 6, and 12-month follow-up, and both groups demonstrated return to baseline internal rotation strength by 3 months postoperatively, regardless of the rehabilitation protocol employed. These findings suggest that the standard phased rehabilitation approach recommended by the American Society of Shoulder and Elbow Therapists is sufficient for restoring subscapularis function in most patients, and that additional subscapularis-focused interventions do not confer measurable benefit. However, it is important to note that this study evaluated patients who had undergone successful subscapularis repair with good tissue quality. Patients with compromised subscapularis tissue, failed prior repairs, or other risk factors for subscapularis insufficiency were excluded and may require more intensive rehabilitation strategies. Furthermore, all patients in both groups adhered to strict subscapularis precautions during the initial 6-week protection phase, underscoring that early tissue protection remains paramount regardless of subsequent strengthening strategies. Serial assessment using validated patient-reported outcome measures is essential for monitoring rehabilitation progress, identifying patients at risk for poor outcomes, and guiding clinical decision-making throughout the postoperative course. The most responsive and internally valid instruments for anatomic arthroplasty populations are the American Shoulder and Elbow Surgeon Score, the Western Ontario Osteoarthritis of the Shoulder Index, the Disabilities of the Arm, Shoulder, and Hand Questionnaire and its abbreviated version QuickDash, and the Simple Shoulder Test. These instruments demonstrate superior responsiveness to change compared to other commonly used measures, with effect sizes exceeding 0.8 for detecting clinically meaningful improvement after surgery. The American Shoulder and Elbow Surgeon Score is particularly advantageous due to its low responder burden, inclusion of both pain and function domains, and extensive validation in arthroplasty populations. A 2024 study confirmed that both the DASH and QuickDash are valid and responsive for anatomic arthroplasty outcome assessment, with minimal clinically important differences of 8 to 10 points for DASH and 10 to 15 points for QuickDash. These instruments should be administered preoperatively to establish baseline status and at regular intervals postoperatively, typically at 6 weeks, 3 months, 6 months, and 1 year, to track recovery trajectories and identify patients who are not progressing as expected. Clinical examination at each rehabilitation visit should include assessment of wound healing, neurovascular status, pain levels, passive and active range of motion in multiple planes, strength of the deltoid and parascapular muscles, and scapulohumeral rhythm during functional movements. Provocative testing for subscapularis integrity, including the belly press test, bear hug test, and liftoff test, should be performed cautiously and only after phase 1, as these maneuvers place significant stress on the subscapularis repair. Any signs of subscapularis failure, including anterior pain, difficulty with internal rotation, or positive provocative tests, should prompt immediate communication with the operating surgeon and consideration for advanced imaging to assess repair integrity. Despite the publication of evidence-based consensus guidelines by the American Society of Shoulder and Elbow Therapists in 2020, significant variability persists in publicly available rehabilitation protocols for anatomic total shoulder arthroplasty. A 2024 cross-sectional study evaluating online protocols from academic medical centers, private practices, and therapy clinics found substantial deviation from American Society of Shoulder and Elbow Therapists recommendations regarding sling immobilization duration, passive range of motion limits, timing of active motion introduction, and strengthening progression. Only 23% of protocols adhered closely to the guidelines across all measured parameters, and wide variability existed even among protocols from high-volume shoulder centers. This variability likely reflects differences in surgeon preference, surgical technique, implant design, and patient populations, but it also highlights the need for improved dissemination and implementation of evidence-based rehabilitation standards. Rehabilitation professionals should be familiar with the American Society of Shoulder and Elbow Therapists Consensus Statement and the American Physical Therapy Association Clinical Practice Guideline, while recognizing that protocol modifications may be necessary based on intraoperative findings, patient-specific factors, and communication with the surgical team. Close collaboration between rehabilitation professionals and surgeons throughout the postoperative course is essential to ensure that rehabilitation intensity and progression are appropriately calibrated to each patient's unique circumstances. The evidence-based phased rehabilitation protocol for anatomic total shoulder arthroplasty that we've discussed provides a framework for delivering high-quality, outcomes-oriented care that balances tissue protection with functional restoration. Adherence to key principles, early but controlled passive mobilization, strict subscapularis precautions during the first 6 weeks, systematic progression through active motion and strengthening phases, and serial assessment using validated outcome measures optimizes the likelihood of achieving excellent functional outcomes while minimizing the risk of complications. Now let's move to Module 3, Evidence-Based Rehabilitation Protocols for Reverse Total Shoulder Arthroplasty. Rehabilitation protocols following reverse total shoulder arthroplasty have evolved dramatically over the past decade, with accumulating high-quality evidence supporting accelerated, function-oriented approaches that depart substantially from the conservative protocols traditionally employed for anatomic arthroplasty. The fundamental biomechanical differences between reverse and anatomic prostheses, including medialization of the center of rotation, recruitment of the deltoid muscle to compensate for rotator cuff deficiency, and inherent prosthetic stability that does not rely on intact rotator cuff function, permit earlier active mobilization and more aggressive functional training in most patients. Traditional rehabilitation protocols for reverse total shoulder arthroplasty, adapted from anatomic arthroplasty guidelines, emphasize prolonged immobilization for 4 to 6 weeks, strict limitations on active motion and weight bearing, and graduated progression through passive, active-assisted, and active range of motion phases over 12 to 16 weeks. This conservative approach was predicated on concerns about subscapularis repair protection, deltoid healing to the acromion and fracture cases, and prosthetic stability. However, recognition that many reverse arthroplasty patients do not undergo subscapularis repair, combined with improved understanding of reverse prosthesis biomechanics and constraint characteristics, prompted investigation of accelerated rehabilitation strategies with minimal or no immobilization and immediate active motion. The most compelling evidence supporting accelerated rehabilitation comes from a 2023 international multi-center prospective cohort safety study that evaluated 100 patients with a mean age of 74 years who underwent direct active rehabilitation following reverse arthroplasty with sling use for only 1 day and immediate progression to active range of motion exercises without specific precautions. At 1-year follow-up, the overall complication rate was 17%, with only 5% of complications potentially related to the rehabilitation strategy. These included 1 dislocation, 1 acromion fracture, and 3 cases of persistent pain, and no instances of implant loosening, paraprosthetic fracture due to physiotherapy, or subscapularis failure. Significant improvements in forward flexion, abduction, external rotation, pain scores, and Oxford Shoulder Score were observed at all time points, with quality of life measures improving from 3 months onward. These findings demonstrated that immediate, active rehabilitation is safe and effective for appropriately selected reverse arthroplasty patients, particularly when the subscapularis is not repaired. A large comparative study published in 2021 evaluated 357 reverse arthroplasty patients randomized to accelerated rehabilitation protocols with no immobilization, 3 weeks of sling use, or 6 weeks of sling use. At 1-year follow-up, the no immobilization group demonstrated non-inferior outcomes compared to both immobilization groups, with constant scores improving from 16.6 to 22.6 preoperatively to 67.7 postoperatively across all groups, and no significant differences in pain, satisfaction, or range of motion. Importantly, the no immobilization group had fewer postoperative complications, particularly those related to falls and mobility impairment, and achieved earlier return to independence in activities of daily living. These findings challenged the assumption that prolonged immobilization enhances safety or outcomes, and instead suggested that early mobilization may reduce complications by preserving functional capacity and preventing deconditioning in elderly patients. Now let's discuss an important question: home-based versus formal physical therapy. This was addressed by the 2025 short trial, which stands for Surgeon-Directed Home Therapy versus Outpatient Rehabilitation by Physical Therapists. This multi-center randomized controlled trial of 222 shoulders definitively addressed whether formal outpatient physical therapy supervised by licensed therapists provides superior outcomes compared to surgeon-directed home exercise programs. The study found no statistically significant differences in range of motion, patient-reported outcomes including the American Shoulder and Elbow Surgeon Score, Simple Shoulder Test, and Visual Analog Scale pain, complications, or revision rates at 1 and 2 years between patients randomized to home-based therapy versus formal outpatient physical therapy. However, the home therapy group demonstrated a significantly lower 1-year care cycle cost of $11,285 compared to $17,837, with a p-value of less than 0.01, confirming substantial cost savings without compromising outcomes. These findings have important implications for rehabilitation practice and resource allocation. While the trial demonstrated that home-based rehabilitation is non-inferior for the majority of patients, it is important to recognize that both groups received structured protocols and regular surgeon follow-up, and that patients with complications, poor early progress, or specific risk factors were able to transition to formal therapy as needed. The results should not be interpreted as suggesting that physical therapy has no value for reverse arthroplasty patients, but rather that appropriately selected and educated patients can achieve excellent outcomes with home programs, and that formal therapy can be reserved for those with complications, complex medical histories, or failure to progress with home exercises. Let's now turn to exercise selection and progression based on electromyographic and kinematic evidence. Contemporary research has applied electromyographic analysis and three-dimensional kinematic assessment to characterize muscle activation patterns and scapular mechanics during commonly prescribed rehabilitation exercises, providing an empirical foundation for exercise selection and progression after reverse arthroplasty. A 2024 study evaluated shoulder muscle activity during 12 rehabilitation exercises in reverse arthroplasty patients at 12 weeks postoperatively, revealing that gravity-minimized exercises in the horizontal plane, such as tabletop slides and horizontal external rotation, elicit low to moderate deltoid activity, while open kinetic chain exercises against gravity, such as forward elevation and abduction, and vertical closed kinetic chain exercises, such as wall push-ups, produce significantly higher muscle activity. These findings support a rehabilitation progression from gravity-minimized exercises in early phases to against gravity open and closed chain exercises as strength and endurance improve. External rotation exercises generated high posterior deltoid and infraspinatus activity even in patients with documented rotator cuff deficiency, suggesting that compensatory posterior deltoid activation partially replaces the absent rotator cuff function. The upper trapezius demonstrated high activity levels across most exercises, reflecting its critical role in scapular stabilization and upward rotation to facilitate overhead motion after reverse arthroplasty. Three-dimensional kinematic analysis of scapular motion during the same exercises revealed that reverse arthroplasty patients achieve scapular positioning and movement patterns similar to healthy controls during most upper extremity tasks, with the exception of end-range elevation activities that require greater scapular upward rotation and posterior tilt. Exercises such as forward elevation, scaption, and wall slides optimally recruit scapular upward rotation and are appropriate for inclusion in early and intermediate rehabilitation phases. Conversely, exercises requiring scapular protraction or internal rotation place higher demands on the scapulothoracic articulation and may be more appropriate for later phases when motor control and endurance are better developed. Now let's discuss a phased rehabilitation protocol for reverse total shoulder arthroplasty. Despite the strong evidence supporting accelerated rehabilitation, systematic reviews consistently identify substantial variability in published protocols with no universal consensus regarding optimal immobilization duration, range of motion restrictions, or strengthening progression. A reasonable evidence-based approach synthesizes current literature into a flexible phased framework that can be individualized based on surgical factors, such as subscapularis repair status, bone quality, and concurrent procedures, patient factors including age, comorbidities, and functional demands, and early rehabilitation response. For uncomplicated reverse arthroplasty without subscapularis repair or tendon transfers, an accelerated protocol is appropriate. This includes sling use for 1 to 3 days for comfort, immediate initiation of active assisted and active range of motion exercises in all planes without external or internal rotation restrictions, and progression to strengthening exercises as tolerated beginning at 6 to 8 weeks postoperatively. Active elevation and external rotation are permitted from the first postoperative week, with emphasis on gravity-minimized positions initially and progression to against-gravity exercises as strength improves. Dislocation precautions, specifically avoiding combined adduction, internal rotation, and extension, should be observed throughout the first 6 to 12 weeks, as this position places the prosthesis at greatest risk for posterior dislocation. Functional training for activities of daily living is integrated early, with patients encouraged to use the operative arm for light tasks such as feeding, grooming, and computer work from the first week postoperatively. For patients undergoing subscapularis repair or tendon transfer procedures in conjunction with reverse arthroplasty, a more conservative protocol is warranted. This includes sling immobilization for 4 to 6 weeks, passive and active assisted range of motion only during the first 6 weeks with external rotation limits typically restricted to 30 degrees, and delayed introduction of active motion and strengthening until adequate healing is confirmed. These patients essentially follow a hybrid protocol that incorporates subscapularis protection similar to anatomic arthroplasty while recognizing the inherent stability and deltoid-dependent mechanics of the reverse prosthesis. Progression from passive to active motion should be based on clinical assessment of pain, motion quality, and subscapularis integrity, with transition to strengthening typically occurring at 10 to 12 weeks postoperatively. Strengthening exercises for reverse arthroplasty focus on the deltoid, scapular stabilizers, and remaining rotator cuff musculature, recognizing that the deltoid is the primary motor for shoulder elevation and that scapulothoracic rhythm is critical for achieving functional overhead motion. Resistance training begins with low loads and high repetitions to promote muscular endurance, with gradual progression in resistance as tolerated. Closed kinetic chain exercises, such as wall push-ups and table push-ups, are introduced once patients demonstrate adequate deltoid strength and motor control, typically at 8 to 12 weeks postoperatively. Open kinetic chain exercises targeting the posterior deltoid and lower trapezius are emphasized to promote balance force couples and optimize scapular positioning during functional activities. Return to recreational activities and sport is individualized based on patient goals, activity demands, and surgeon recommendations. Low-impact activities such as swimming, golf, and light resistance training can typically be initiated at 4 to 6 months postoperatively, while high-impact or contact activities require careful assessment and may not be appropriate for all reverse arthroplasty patients given the altered biomechanics and potential for implant wear or loosening with repetitive high loading. Patients should be counseled that while reverse arthroplasty reliably restores the ability to perform overhead activities of daily living and recreational pursuits, the prosthesis is not designed to withstand the forces generated during high-level athletic competition or heavy labor, and activity modification may be necessary to preserve long-term implant survival. Systematic reviews evaluating physiotherapy interventions after reverse arthroplasty have quantified the effectiveness of rehabilitation using meta-analytic techniques. A 2025 systematic review of 12 studies involving 638 patients found that multimodal physiotherapy programs combining progressive exercise, manual therapy, and patient education produce moderate effect sizes, with Cohen's d values of 0.47 to 0.56 for improvements in function, range of motion, and quality of life. Early rehabilitation intervention, defined as initiation within the first postoperative week, demonstrated an effect size of 0.52 for functional improvement, compared to delayed intervention beginning at 4 to 6 weeks, although both approaches ultimately yielded substantial benefits by 6 to 12 months postoperatively. The clinical significance of these effect sizes must be interpreted in the context of the profound functional deficits typical of reverse arthroplasty candidates, who often present with pseudoparalysis, severe pain, and inability to perform basic overhead activities. Even moderate effect sizes translate to meaningful improvements in the ability to dress, groom, reach overhead shelves, and perform household tasks, representing substantial gains in independence and quality of life for elderly patients with rotator cuff arthropathy. Furthermore, the consistency of benefit across studies with different rehabilitation protocols suggests that the inherent biomechanical advantages of the reverse prosthesis, including stable kinematics and deltoid-driven elevation, contribute substantially to functional improvement independent of rehabilitation intensity. While accelerated rehabilitation protocols have demonstrated safety in well-designed studies, rehabilitation professionals must remain vigilant for complications that can occur after reverse arthroplasty, including dislocation, periprosthetic fracture, infection, and persistent pain or stiffness. Dislocation rates in contemporary series range from 0.7 to 3%, with posterior dislocation being the most common direction due to the altered mechanics of the reverse prosthesis. Patients with metabolic syndrome, including diabetes, obesity, and hypertension, prior shoulder surgery, or revision procedures are at higher risk for complications and may benefit from more conservative rehabilitation approaches. Acromial or scapular spine fractures, while uncommon with an incidence of 0.8%, represent a potentially serious complication that can occur secondary to altered stress distribution with the reverse prosthesis or from trauma, such as falls. Rehabilitation professionals should maintain a high index of suspicion for fracture in patients who develop acute onset of pain, loss of elevation, or palpable tenderness over the acromion or scapular spine, and should promptly refer such patients for radiographic evaluation and surgical consultation. Scapular notching, defined as inferior glenoid erosion from contact with the humeral polyethylene component during adduction, occurs in up to 14% of patients but is typically asymptomatic and does not require modification of rehabilitation protocols. Infection after reverse arthroplasty occurs at rates of 1 to 2% and may present acutely with fever, wound drainage, and erythema, or as a delayed low-grade infection with persistent pain and functional limitation. Any patient with signs concerning for infection should be immediately referred to the surgical team for evaluation, including laboratory studies such as complete blood count, C-reactive protein, and erythrocyte sedimentation rate, and possibly joint aspiration for culture. Rehabilitation should be suspended until infection is definitively ruled out or treated. The evidence base supporting accelerated rehabilitation after reverse arthroplasty continues to evolve, with ongoing research addressing optimal protocols for specific patient populations, including the elderly with multiple comorbidities, revision cases, and fracture indications, and investigating the role of novel interventions such as blood flow restriction training, neuromuscular electrical stimulation, and telehealth-based rehabilitation. Rehabilitation professionals should remain current with emerging evidence, collaborate closely with referring surgeons to understand case-specific considerations, and individualize protocols based on patient response and progression. The accelerated rehabilitation paradigm for reverse arthroplasty represents a significant departure from traditional approaches and offers the potential to reduce healthcare costs, improve patient satisfaction through earlier functional recovery, and optimize resource allocation by reserving formal therapy for patients who truly require intensive intervention. Now let's move to Module 4, Complications Following Total Shoulder Arthroplasty, focusing on identification and management. Complications following total shoulder arthroplasty, while relatively uncommon in contemporary practice, can significantly compromise functional outcomes, patient satisfaction, and quality of life when they occur. Rehabilitation professionals play a critical role in the early identification of complications through systematic clinical assessment, appropriate use of outcome measures to detect deviations from expected recovery trajectories, and timely communication with the surgical team to coordinate diagnostic evaluation and intervention. Large-scale registry studies and meta-analyses published between 2021 and 2025 provide robust data on complication incidence, types, and risk factors following both anatomic and reverse total shoulder arthroplasty. A 2022 systematic review and meta-analysis of primary reverse arthroplasty, including over 5,000 patients with minimum 2-year follow-up, reported an overall complication rate of 8.9 to 12.5% and a revision rate of 2.5 to 2.6% at mean follow-up of 3.9 years. The most frequent complications following reverse arthroplasty are scapular notching at 14.4%, periprosthetic fracture at 0.8%, glenoid loosening at 0.7%, and prosthetic dislocation at 0.7%, with infection occurring in approximately 1 to 2% of cases. Implant survival rates for reverse arthroplasty exceed 95% at 11 years in most contemporary series, reflecting substantial improvements in prosthetic design, surgical technique, and patient selection over the past decade. Comparative studies demonstrate that complication and revision rates differ between anatomic and reverse arthroplasty, with the specific complication profile reflecting the distinct biomechanics and soft tissue demands of each prosthetic design. A 2021 analysis of over 75,000 shoulder arthroplasties from a large institutional database found that the overall complication rate was 10.7% for anatomic arthroplasty compared to 8.9% for reverse arthroplasty, and the revision rate was 5.6% for anatomic compared to 2.5% for reverse arthroplasty. The most common complications following anatomic arthroplasty are rotator cuff tear or subscapularis failure at 3.1%, aseptic glenoid loosening at 2.5%, infection at 1.3%, and instability at 1.2%. These data underscore that soft tissue-related complications, particularly subscapularis insufficiency and secondary rotator cuff dysfunction, represent the predominant failure mechanisms for anatomic arthroplasty, while reverse arthroplasty complications are more often related to implant-bone interface issues or prosthetic instability. Readmission rates provide an additional measure of postoperative morbidity and healthcare utilization. A 2023 analysis of the National Readmissions Database, including over 180,000 shoulder arthroplasties, found that 30-day and 90-day readmission rates were 3.63% and 7.76% for reverse arthroplasty and 1.92% and 4.37% for anatomic arthroplasty, respectively. The leading causes of readmission are prosthetic dislocation and infection for both procedures, highlighting the importance of early identification and management of these potentially catastrophic complications. Rehabilitation professionals should maintain a high index of suspicion for complications in any patient who presents with acute changes in pain, function, or clinical examination findings, and should promptly communicate concerns to the surgical team rather than attributing symptoms to normal postoperative recovery. Subscapularis tendon failure represents one of the most common and functionally significant complications following anatomic total shoulder arthroplasty, occurring in approximately 3 to 5% of patients in contemporary series. The subscapularis is typically tenotomized or peeled from the lesser tuberosity to provide surgical exposure during anatomic arthroplasty, and secure anatomic repair at the conclusion of the procedure is critical for restoring anterior stability, internal rotation strength, and preventing eccentric loading of the prosthesis. Failure of the subscapularis repair results in anterior shoulder pain, weakness of internal rotation, subjective instability, or dead arm sensation with forward elevation, and increased risk of anterior prosthetic subluxation or dislocation. Clinical examination findings suggestive of subscapularis insufficiency include positive belly press test, bear hug test, and liftoff test, although sensitivity and specificity of these provocative maneuvers in the postoperative arthroplasty population are not well established. Patients may demonstrate compensatory recruitment of the pectoralis major and latissimus dorsi muscles during internal rotation efforts, and may report difficulty with activities requiring internal rotation such as tucking in shirts, fastening bra, or reaching the perineum for hygiene. Advanced imaging with magnetic resonance imaging using metal artifact reduction sequences or ultrasound evaluation by an experienced musculoskeletal sonographer can confirm the diagnosis, although sensitivity for detecting partial tears may be limited. Management of subscapularis insufficiency depends on the severity of dysfunction, timing of diagnosis, and impact on patient function and satisfaction. Mild to moderate insufficiency detected early, within 3 to 6 months postoperatively, may respond to intensive rehabilitation focused on compensatory strengthening of the pectoralis major and anterior deltoid, scapular stabilization exercises, and activity modification to avoid positions that stress the failed repair. For patients with severe insufficiency, persistent pain, or functional limitation that does not improve with conservative management, surgical options include revision subscapularis repair if tissue quality permits, pectoralis major tendon transfer to restore anterior force couple balance, or conversion to reverse arthroplasty to eliminate reliance on subscapularis function. A 2022 review of management strategies for subscapularis insufficiency after anatomic arthroplasty emphasized that early recognition and intervention are critical, as chronic insufficiency results in progressive anterior capsular laxity, eccentric glenoid wear, and ultimately prosthetic failure requiring complex revision surgery. Aseptic loosening of the glenoid component, defined as progressive radial lucency at the bone implant interface or component migration without evidence of infection, remains a long-term concern following anatomic total shoulder arthroplasty, with incidence rates of 2 to 5% at 5 to 10-year follow-up in contemporary series. Loosening is typically asymptomatic in early stages and detected on routine surveillance radiographs as progressive radiolucent lines surrounding the glenoid component, but eventually manifests as pain with loading, grinding, or catching sensations, and loss of function as component subsidence and eccentric wear progress. Risk factors for glenoid loosening include rotator cuff deficiency or secondary cuff dysfunction leading to superior humeral migration and eccentric loading, glenoid component malposition, particularly superior tilt, poor bone quality, and suboptimal cementing technique. Clinical presentation of symptomatic glenoid loosening includes progressively worsening pain with shoulder use, particularly with loading activities such as lifting or pushing, and patients may report grinding, clicking, or catching sensations with motion. Physical examination may reveal tenderness over the anterior or posterior glenoid, pain with resisted internal or external rotation, and decreased active range of motion due to pain inhibition. Plain radiographs are the initial imaging modality and typically demonstrate progressive radiolucent lines greater than 2 mm in width, component migration, or eccentric humeral head positioning relative to the glenoid. Advanced cross-sectional imaging with computed tomography or magnetic resonance imaging may be required to definitively characterize the extent of bone loss and guide revision surgical planning. Management of asymptomatic glenoid loosening detected on surveillance radiographs is controversial, with some surgeons advocating for close observation and others recommending preemptive revision before substantial bone loss occurs. For symptomatic loosening with significant pain or functional limitation, revision surgery is typically indicated, with options including isolated glenoid component revision if humeral component and soft tissues are well preserved, revision to alternative glenoid component designs such as metal-backed or augmented components to address bone deficiency, or conversion to reverse arthroplasty to eliminate glenoid component loading through medialization of the center of rotation. Secondary rotator cuff dysfunction, defined as progressive deterioration of previously intact rotator cuff tendons following anatomic total shoulder arthroplasty, represents a concerning complication that increases in incidence over time and is associated with worse clinical and radiographic outcomes. The pathophysiology of secondary cuff dysfunction is multifactorial and includes age-related tendon degeneration, trauma, iatrogenic injury during surgical dissection, and altered biomechanics related to prosthetic positioning or subscapularis insufficiency. Patients with advanced age, preoperative rotator cuff thinning or partial tears, fatty infiltration of cuff muscles, particularly the infraspinatus, and multiple prior shoulder surgeries are at highest risk for secondary cuff failure. Clinical presentation of secondary rotator cuff dysfunction includes progressive loss of active elevation despite preserved passive motion, weakness of external rotation, positive external rotation lag sign or drop arm test, and superior migration of the humeral head on radiographs. Patients may initially compensate through deltoid and scapular substitution but eventually develop painful pseudoparalysis characterized by inability to actively elevate the arm above shoulder level. Advanced imaging with magnetic resonance imaging or ultrasound is required to confirm rotator cuff tearing and assess the size, retraction, and fatty infiltration of the affected muscles. Management depends on the severity of dysfunction, timing of diagnosis, and patient functional demands and expectations. Small partial thickness tears detected early may be managed conservatively with activity modification, scapular strengthening to optimize compensatory mechanics, and avoidance of overhead loading. Larger symptomatic tears that are potentially repairable may be addressed with arthroscopic or open rotator cuff repair, although success rates are lower in the setting of prosthetic arthroplasty due to altered anatomy, scar tissue, and tendon quality concerns. For patients with massive irreparable cuff tears and significant functional impairment, conversion to reverse total shoulder arthroplasty represents the definitive solution, with predictable improvement in pain and overhead function by recruiting the deltoid to compensate for absent cuff function. A 2025 systematic review of outcomes following conversion from failed anatomic to reverse arthroplasty reported substantial improvements in pain and function, with complication rates of 10 to 15% and revision rates of 5 to 8% at midterm follow-up, confirming that salvage with reverse arthroplasty is a viable option for this challenging problem. Paraprosthetic joint infection following shoulder arthroplasty, while uncommon with an incidence of 1 to 2%, represents a catastrophic complication associated with prolonged morbidity, multiple surgical procedures, substantial healthcare costs, and compromised functional outcomes even with successful treatment. Prevention through meticulous surgical technique, appropriate antibiotic prophylaxis, and optimization of host factors, particularly glycemic control in diabetic patients, is paramount. Patients with diabetes, obesity, inflammatory arthritis, immunosuppression, prior shoulder surgery, and prolonged operative time are at increased risk for postoperative infection. Acute postoperative infection typically presents within the first 4 to 6 weeks following surgery with fever, wound drainage, erythema, warmth, and progressive pain. Delayed or chronic infection may present insidiously with persistent pain, stiffness, and functional limitation months to years after surgery, often without obvious signs of acute inflammation. Rehabilitation professionals should maintain a high index of suspicion for infection in any patient with persistent or worsening pain beyond the expected recovery timeline. Constitutional symptoms such as fever or malaise or wound drainage at any point in the postoperative course. Immediate referral to the surgical team is indicated when infection is suspected, as delays in diagnosis and treatment are associated with worse outcomes. Diagnostic evaluation includes laboratory studies such as complete blood count, erythrocyte sedimentation rate, and C-reactive protein, plain radiographs to assess for prosthetic loosening or bone destruction, and joint aspiration for cell count, differential, gram stain, and aerobic and anaerobic cultures. Serum inflammatory markers are typically elevated in acute infection but may be normal or only mildly elevated in chronic low-grade infection, limiting their sensitivity. Joint aspiration has high specificity but variable sensitivity, particularly if antibiotics have been administered prior to aspiration, and multiple aspirations or open biopsy may be required to establish a microbiologic diagnosis. Management of paraprosthetic shoulder infection depends on the timing of diagnosis, infecting organism, host factors, and status of the implant and soft tissues. Acute postoperative infection within 4 weeks of surgery with a well-fixed implant and virulent organism may be treated with irrigation and debridement with retention of components combined with organism-specific intravenous antibiotics for 6 weeks. Chronic infection or acute infection with a loose implant typically requires staged revision surgery consisting of explantation of all prosthetic components, debridement of infected and necrotic tissue, placement of an antibiotic-impregnated cement spacer, 6 weeks of intravenous antibiotics, and delayed reimplantation once infection is eradicated. Rehabilitation during the spacer period focuses on maintaining passive range of motion and preventing frozen shoulder while avoiding active strengthening that could compromise the temporary spacer construct. Following reimplantation, rehabilitation follows standard protocols for the prosthetic type implanted, although progression may be slower and outcomes are generally inferior to primary arthroplasty. Prosthetic dislocation occurs in approximately 1 to 3% of shoulder arthroplasties, with higher rates following reverse compared to anatomic arthroplasty, and with posterior dislocation being the most common direction for reverse prostheses due to the inverted biomechanics. Risk factors for dislocation include subscapularis insufficiency, deltoid dysfunction, component malposition, inadequate soft tissue tensioning, obesity, neurological disorders, and prior shoulder surgery. Patients with metabolic syndrome, a constellation of diabetes, hypertension, and obesity, have significantly increased rates of dislocation after reverse arthroplasty, with some studies reporting relative risks exceeding 2.0 compared to patients without metabolic syndrome. Acute dislocation presents with severe pain, inability to move the shoulder, visible deformity, and palpable displacement of the humeral head relative to the glenoid. Patients should be immediately referred to an emergency department for radiographic confirmation and close reduction under sedation. Chronic subluxation or microinstability may present more subtly with recurrent clicking, catching, sense of the shoulder slipping, and apprehension with specific positions, particularly combined adduction, internal rotation, and extension for reverse arthroplasty. Physical examination may reveal abnormal glenohumeral translation, apprehension signs, or reproduction of instability symptoms with provocative positioning. Management of a first-time dislocation typically consists of closed reduction followed by a period of immobilization for 3 to 6 weeks and gradual resumption of range of motion and strengthening with avoidance of positions that predispose to recurrent instability. Recurrent dislocation is an indication for revision surgery, with options including soft tissue repair or reconstruction to restore capsular tension, component revision to optimize version and offset, or conversion to alternative implant designs with enhanced constraint. Rehabilitation after dislocation and reduction emphasizes strict adherence to precautions to prevent recurrence, graduated progression of motion with avoidance of provocative positions, and close monitoring for signs of recurrent instability. Persistent or recurrent pain following shoulder arthroplasty represents a challenging diagnostic and management problem that requires systematic evaluation to identify the underlying cause and guide appropriate intervention. A 2023 comprehensive review of the painful total shoulder arthroplasty emphasized that a methodical approach incorporating history, physical examination, laboratory studies, imaging, and when necessary diagnostic arthroscopy is essential to differentiate among the diverse potential etiologies including infection, component loosening, instability, rotator cuff failure, neurologic injury, referred pain, and psychosocial factors. The history should elucidate the onset, location, quality, and temporal pattern of pain, as well as associated symptoms such as stiffness, instability, weakness, and functional limitation. Pain that is constant, present at rest, and worsening over time suggests infection, loosening, or progressive soft tissue failure, while pain that is primarily activity-related and relieved by rest is more consistent with mechanical issues such as impingement, instability, or incipient loosening. Physical examination should assess active and passive range of motion, strength, provocative tests for instability and rotator cuff integrity, and palpation for tenderness over implant components or surrounding soft tissues. Neurovascular examination is essential to rule out nerve injury, cervical radiculopathy, or complex regional pain syndrome. Laboratory evaluation with complete blood count, erythrocyte sedimentation rate, and C-reactive protein is indicated when infection is suspected, although normal values do not exclude low-grade infection. Plain radiographs in multiple views are the initial imaging study and should assess component position, bone implant interfaces for radiolucencies suggesting loosening, humeral head position relative to the glenoid, and bone quality. Advanced imaging with computed tomography provides optimal assessment of bone and implant position, while magnetic resonance imaging with metal artifact reduction sequences is preferred for evaluating soft tissues including the rotator cuff, labrum, and surrounding muscles. When history, examination, laboratory studies, and imaging do not establish a diagnosis, diagnostic arthroscopy may be indicated to directly visualize the glenohumeral joint, assess implant stability, evaluate rotator cuff and labral integrity, and obtain tissue samples for culture and pathology. Rehabilitation professionals should recognize that persistent pain beyond 6 to 12 months postoperatively, particularly when accompanied by functional limitation or loss of motion, warrants comprehensive diagnostic evaluation rather than continued attempts at conservative management, as timely diagnosis and treatment of underlying complications improves the likelihood of successful outcomes. Long-term surveillance following shoulder arthroplasty includes periodic clinical evaluation and radiographic assessment to detect complications before they become symptomatic or progress to irreversible bone loss or soft tissue damage. Most surgeons recommend clinical and radiographic follow-up at 6 weeks, 3 months, 6 months, 1 year, and annually thereafter, although optimal surveillance intervals are not definitively established by high-quality evidence. Patients should be educated regarding warning signs of complications including new or worsening pain, loss of motion or strength, instability symptoms, fever, or wound drainage, and instructed to seek prompt evaluation if any concerning symptoms develop. Implant survivorship data from contemporary series demonstrate that both anatomic and reverse total shoulder arthroplasty provide durable functional improvement and high patient satisfaction extending beyond 10 years, with revision rates remaining low when patients are appropriately selected and complications are identified and addressed early. A 2025 prospective cohort study with minimum 11-year follow-up reported implant survival of 95.3% and sustained improvement in pain, function, and quality of life for reverse arthroplasty patients, although patients with prior surgery or indications other than cuff tear arthropathy had higher complication and revision rates. These data emphasize the importance of appropriate patient selection, meticulous surgical technique, evidence-based rehabilitation, and long-term surveillance to optimize outcomes and implant longevity. Rehabilitation professionals contribute to long-term success by providing education regarding activity modification and joint protection, prescribing maintenance exercise programs to preserve shoulder flexibility and strength, monitoring for early signs of complications during ongoing care, and communicating with the surgical team when concerns arise. The systematic approach to complication identification and management we've discussed equips rehabilitation professionals with the knowledge and clinical reasoning skills necessary to recognize deviations from expected recovery, initiate appropriate diagnostic pathways, and coordinate evidence-based interventions that optimize patient outcomes and satisfaction following total shoulder arthroplasty. Now let's move to Module 5, Rehabilitation Adaptations for High-Risk Populations. Optimal rehabilitation following total shoulder arthroplasty requires recognition that certain patient populations experience elevated rates of complications, inferior functional outcomes, and unique challenges that necessitate protocol modifications and intensive clinical management. High-risk populations include patients with diabetes mellitus, prior ipsilateral shoulder surgery including revision arthroplasty procedures, pre-existing or secondary rotator cuff pathology, depression and chronic pain syndromes, obesity, rheumatoid arthritis and other inflammatory conditions, and patients with multiple medical comorbidities as quantified by validated comorbidity indices. Diabetes mellitus affects approximately 15 to 25% of patients undergoing shoulder arthroplasty, and substantial evidence published between 2022 and 2025 demonstrates that diabetic patients face increased risks for perioperative complications, prolonged hospital stays, non-homebound discharge, and elevated healthcare costs compared to non-diabetic patients. A 2023 national readmission study of over 113,000 shoulder arthroplasty patients found that diabetes was associated with significantly increased risk for 90-day readmission, postoperative infection, respiratory complications, and deep vein thrombosis. These elevated risks persist even after controlling for other comorbidities and patient demographic factors, underscoring that diabetes represents an independent predictor of adverse outcomes. The relationship between glycemic control, as measured by perioperative hemoglobin A1C levels, and postoperative complications has been extensively investigated, although optimal hemoglobin A1C thresholds for shoulder arthroplasty remain incompletely defined. A 2019 Kaiser Permanente registry study of over 5,000 shoulder arthroplasties found that neither hemoglobin A1C level nor disease severity as measured by the Adapted Diabetes Complication Severity Index was strongly associated with risk of deep infection, all-cause revision, or 90-day readmission, challenging the assumption that glycemic control directly predicts these outcomes in the shoulder arthroplasty population. However, a 2025 comprehensive review noted that when extrapolating from lower extremity arthroplasty literature, the optimal hemoglobin A1C threshold is most likely in the range of 7.5 to 8.0%, and that perioperative glycemic optimization remains a reasonable goal to minimize infection risk. More nuanced evidence suggests that controlled diabetes with hemoglobin A1C less than 7.0% is not associated with increased complication rates compared to non-diabetic patients, while poorly controlled diabetes with hemoglobin A1C greater than 8.0% confers elevated risk. A 2024 single-center retrospective study found no significant differences in complications, readmissions, or functional outcomes between patients with controlled diabetes and non-diabetic patients undergoing anatomic or reverse arthroplasty, suggesting that appropriate perioperative medical management can mitigate diabetes-related risks. These findings emphasize the importance of preoperative assessment of glycemic control, coordination with endocrinology, or primary care providers to optimize diabetes management before surgery and continued vigilance for hyperglycemia and its complications throughout the postoperative period. Rehabilitation protocol modifications for diabetic patients center on enhanced infection surveillance, meticulous wound care, and individualized progression based on healing status rather than rigid adherence to time-based milestones. Wound assessment should be performed at every therapy visit, with particular attention to erythema, warmth, drainage, dehiscence, or other signs concerning for superficial or deep infection. Patients should be educated regarding the signs and symptoms of infection and instructed to seek immediate medical evaluation if fever, chills, or wound drainage develop. Glycemic control should be monitored in collaboration with the patient's medical providers, as hyperglycemia during the immediate postoperative period is associated with impaired wound healing and increased infection risk. Rehabilitation progression may need to be slower in diabetic patients with poor glycemic control, particularly during the early phases when tissue healing is most vulnerable, with criteria for phase advancement individualized based on wound healing, pain control, and absence of complications rather than strict adherence to protocol timelines. Prior ipsilateral shoulder surgery, including prior arthroplasty, rotator cuff repair, fracture fixation, or instability procedures, represents a significant risk factor for inferior outcomes and elevated complication rates following shoulder arthroplasty. A 2024 systematic review of patient-related prognostic factors found that prior shoulder surgery independently doubles the risk of poor medium to long-term functional outcomes, with odds ratios exceeding 2.0 for persistent pain and functional limitation. Patients with prior surgery experience higher rates of intraoperative complications, including difficulty with component positioning, compromised bone quality, and inadequate soft tissue coverage, as well as postoperative complications including infection, stiffness, instability, and need for revision surgery. Revision arthroplasty, defined as removal and replacement of one or more prosthetic components, presents unique challenges due to altered anatomy, scar tissue, bone loss, soft tissue deficiency, and the inherent complexity of achieving stable fixation and appropriate soft tissue tensioning in the setting of compromised host tissues. Patients undergoing revision procedures have inferior functional outcomes and higher complication rates compared to primary arthroplasty, although substantial improvements in pain and function can still be achieved in most patients. A 2025 systematic review of revision from failed anatomic to reverse arthroplasty reported mean improvements in American shoulder and elbow surgeon scores of 30 to 40 points and 40 elevation of 40 to 60 degrees, with complication rates of 10 to 15% and revision rates of 5 to 8% at midterm follow-up. These outcomes, while inferior to primary arthroplasty, represent meaningful functional restoration for patients with failed prior procedures. Rehabilitation protocol adaptations for patients with prior shoulder surgery and revision arthroplasty include more conservative progression through rehabilitation phases, prolonged immobilization when indicated by tissue quality or bone healing requirements, and individualized criteria for phase advancement based on clinical assessment rather than fixed timelines. Communication between the rehabilitation professional and the operating surgeon is critical to understand intraoperative findings, the quality and integrity of repaired or reconstructed tissues, any augmentation procedures performed such as bone grafting or allograft reconstruction, and specific precautions or restrictions that should be observed. Patients with revision procedures may require extended periods of passive-only range of motion, 8 to 12 weeks, before active motion is introduced, particularly when tendon transfers or complex soft tissue reconstructions have been performed. Strengthening exercises should be delayed until adequate tissue healing is confirmed, typically not before 12 to 16 weeks postoperatively. Functional expectations must be carefully managed, as patients with revision procedures are less likely to achieve new normal shoulder function and may have persistent limitations in range of motion, strength, and ability to perform high-demand activities. However, the goals of pain relief, restoration of independence, and basic activities of daily living and improved quality of life are achievable in the majority of patients when rehabilitation is appropriately individualized and complications are promptly identified and addressed. Psychological factors including depression, anxiety, Chronic pain catastrophizing and pain-related fear avoidance represent increasingly recognized predictors of inferior outcomes following shoulder arthroplasty, with effect sizes comparable to or exceeding those of many medical comorbidities. A 2024 systematic review of patient-related prognostic factors identified depression as a strong and consistent predictor of worse pain and function scores after shoulder arthroplasty, with patients experiencing depression reporting American shoulder and elbow surgeons scores 10 to 15 points lower than non-depressed patients at one-year follow-up. Depression is also associated with increased rates of irrigation and debridement for infection, higher opioid consumption, and greater likelihood of persistent opioid use beyond the acute postoperative period. Chronic pain diagnoses, including fibromyalgia, chronic back pain, and widespread pain syndromes, are similarly associated with inferior functional recovery and lower patient satisfaction following shoulder arthroplasty. A 2025 study of comorbidity-specific complication risks found that chronic back pain and systemic lupus erythematosus were associated with markedly increased rates of revision surgery for rotator cuff pathology, with odds ratios exceeding 3.0 compared to patients without these conditions. These findings reflect the complex interactions between central pain sensitization, altered pain processing, psychological distress, and functional limitation that characterize chronic pain conditions and influence recovery from surgical interventions. Preoperative screening for depression and anxiety using validated instruments such as the Patient Health Questionnaire 9 or Generalized Anxiety Disorder 7 scale is recommended to identify at-risk patients who may benefit from targeted interventions. Patients with significant psychological symptoms should be referred for mental health evaluation and treatment, as optimizing mood and anxiety disorders preoperatively may improve postoperative outcomes. Postoperative rehabilitation should incorporate psychological support, cognitive behavioral strategies for pain management, and multidisciplinary coordination with mental health professionals when indicated. Realistic expectation management is critical, as patients with depression or chronic pain are less likely to achieve substantial clinical benefit or patient-acceptable symptom state thresholds despite meaningful objective improvements in pain and function. Rehabilitation protocol modifications include close monitoring for signs of inadequate pain control, catastrophic thinking, or non-adherence to prescribed exercises, with early intervention through adjustment of pain management strategies, increased education and support, or referral to psychology or psychiatry services when appropriate. Multimodal analgesia emphasizing non-opioid agents, regional anesthesia, and non-pharmacologic pain management techniques is particularly important in this population to minimize opioid exposure and dependence risk. The goal is to optimize psychological and emotional well-being alongside physical recovery, recognizing that addressing the whole patient rather than focusing solely on the shoulder is essential for achieving satisfactory outcomes in individuals with comorbid psychological conditions. Obesity, defined as body mass index greater than or equal to 30 kilograms per meter squared, affects a substantial proportion of shoulder arthroplasty patients and is associated with increased perioperative risks including wound complications, infection, venous thromboembolism, and respiratory complications. Metabolic syndrome, a constellation of cardiovascular risk factors including obesity, hypertension, diabetes, and dyslipidemia, confers particularly elevated risk for postoperative complications. A 2021 study found that patients with metabolic syndrome undergoing reverse arthroplasty experienced significantly higher rates of deep infection compared to patients without metabolic syndrome, with relative risks exceeding 2.0. Despite these elevated complication risks, functional outcomes following shoulder arthroplasty in obese patients are generally favorable, with meaningful improvements in pain and function comparable to non-obese patients, although absolute postoperative scores may be lower. Rehabilitation professionals should be aware that obese patients may have greater difficulty with certain exercises and functional activities due to body habitus, and that modifications such as use of assistive devices for reaching exercises, performance of strengthening exercises in gravity-minimized positions when necessary, and incorporation of aerobic conditioning and weight management counseling may be appropriate. Wound care is particularly critical in obese patients, as increased adipose tissue impairs healing and increases susceptibility to superficial and deep infection. Close inspection of the surgical incision at every therapy visit, patient education regarding wound care and signs of infection, and prompt communication with the surgical team if concerns arise are essential elements of rehabilitation in this population. Progression through rehabilitation phases should be based on wound healing status and absence of complications, with individualized criteria rather than rigid adherence to protocol timelines. Rheumatoid arthritis and other inflammatory arthropathies present unique challenges for shoulder arthroplasty rehabilitation due to compromised tissue quality, altered bone density, immunosuppression related to disease-modifying antirheumatic drugs and biologic agents, and elevated risk for infection and implant loosening. Patients with rheumatoid arthritis require particularly close coordination among the rehabilitation team, orthopedic surgeon, and rheumatologist to optimize disease activity, adjust immunosuppressive medications perioperatively, and monitor for complications. The American College of Rheumatology recommends comprehensive, tailored physical and occupational therapy for rheumatoid arthritis patients undergoing joint replacement, with emphasis on maintaining joint mobility, optimizing strength within the constraints of inflammatory disease, and protecting vulnerable joints from excessive loading. Rehabilitation protocol modifications for patients with inflammatory arthritis include more conservative progression, particularly during disease flares when joint inflammation may compromise tissue healing and increase fracture risk. Exercises should be performed within comfortable ranges of motion, avoiding excessive force or loading that could damage inflamed tissues or fracture osteopenic bone. Aquatic therapy may be particularly beneficial in this population, as the buoyancy of water reduces joint loading while allowing for active motion and strengthening. Close monitoring for infection is paramount, given the immunosuppression associated with both the underlying disease and its pharmacologic treatment. The concept of medical optimization, systematic preoperative assessment, and intervention to address modifiable risk factors and optimize physiologic reserve has gained increasing emphasis in elective orthopedic surgery, including shoulder arthroplasty. A 2023 comprehensive review outlined key components of medical optimization, including management of anemia, nutritional assessment and supplementation, smoking cessation, optimization of chronic medical conditions, particularly diabetes, cardiovascular disease, and chronic obstructive pulmonary disease, medication review and adjustment, and psychological screening and support. Implementation of formal preoperative optimization programs has been shown to reduce complication rates, shorten hospital stays, and improve functional outcomes in total joint arthroplasty populations. Rehabilitation professionals contribute to medical optimization through preoperative education regarding postoperative expectations and rehabilitation requirements, initiation of prehabilitation exercise programs to optimize baseline strength and range of motion, and identification of barriers to postoperative compliance such as limited social support, inadequate home environment, or cognitive impairment that may require additional resources or alternative discharge planning. Postoperatively, close communication with the patient's medical providers regarding glycemic control, pain management, nutrition, and management of comorbid conditions is essential to facilitate optimal recovery. Multimodal analgesia strategies emphasizing non-opioid medications, regional anesthesia techniques, and non-pharmacologic interventions represent an important component of perioperative optimization. A 2022 randomized controlled trial demonstrated that a postoperative multimodal opioid-sparing protocol combining acetaminophen, nonsteroidal anti-inflammatory drugs, and gabapentin significantly reduced opioid consumption after shoulder arthroscopy without compromising pain control or patient satisfaction. While this study evaluated arthroscopic procedures rather than arthroplasty, the principles are applicable and support the use of multimodal analgesia to minimize opioid exposure and associated adverse effects, including sedation, constipation, respiratory depression, and risk for persistent opioid use. However, medication selection must be individualized based on patient-specific contraindications and risk factors. Nonsteroidal anti-inflammatory drugs should be used cautiously in elderly patients and those with renal insufficiency, cardiovascular disease, or gastrointestinal disorders, and should generally be avoided in patients requiring bone healing, such as those with bone grafting procedures. Glucocorticoids and selective serotonin reuptake inhibitors have been associated with increased revision rates following shoulder arthroplasty and should be used judiciously when alternative agents are available. Close collaboration between rehabilitation professionals, surgeons, pain specialists, and pharmacists is essential to design safe and effective pain management strategies tailored to each patient's unique risk profile. Serial assessment using validated patient-reported outcome measures is particularly important in high-risk populations to track recovery trajectories, identify patients who are not progressing as expected, and guide clinical decision-making regarding protocol modifications or need for additional interventions. The American Shoulder and Elbow Surgeon Score, Western Ontario Osteoarthritis of the Shoulder Index, Disabilities of the Arm, Shoulder, and Hand Questionnaire and Quick Dash, and Shoulder Pain and Disability Index have all been validated for use in shoulder arthroplasty populations, including those with comorbidities. These instruments demonstrate responsiveness to change and sensitivity for detecting clinically meaningful improvement, with minimal clinically important differences established for most measures. Importantly, patients with higher comorbidity burden typically report lower baseline scores and achieve smaller absolute improvements compared to healthier patients, although the relative magnitude of change and patient satisfaction with outcomes may be comparable. A 2021 study found that higher Charlson and Elixhauser comorbidity indices were associated with lower American shoulder and elbow surgeon scores and greater pain interference at all time points following shoulder arthroplasty, but that most patients achieved clinically meaningful improvement regardless of comorbidity burden. These findings underscore the importance of establishing realistic expectations based on baseline functional status and comorbidity profile, while recognizing that meaningful functional restoration is achievable even in complex, high-risk patients when rehabilitation is appropriately individualized and complications are promptly addressed. The evidence-based protocol adaptations and interdisciplinary care coordination strategies we've discussed provide rehabilitation professionals with a framework for delivering high-quality, outcomes-oriented care to high-risk populations undergoing total shoulder arthroplasty. Recognition of comorbidity-specific risks, implementation of targeted protocol modifications, close monitoring for complications, and integration of medical optimization principles are essential to achieve satisfactory functional recovery and patient satisfaction in these challenging and increasingly prevalent patient populations. Let's now move to our final module, Module 6, Case Studies focusing on clinical application and decision-making. This module presents 3 comprehensive case studies illustrating evidence-based surgical decision-making and individualized rehabilitation protocols across diverse clinical scenarios. We'll examine a younger active patient undergoing anatomic arthroplasty, an elderly patient with rotator cuff arthroplasty undergoing reverse arthroplasty, and a complex revision case. Let's begin with case study 1, anatomic total shoulder arthroplasty in a younger, active patient. A 58-year-old male recreational golfer and cyclist presented with progressive right shoulder pain, rated 6 out of 10 at rest and 8 out of 10 with activity, and functional limitation unresponsive to conservative management. His medical history included well-controlled hypertension only. He was a non-smoker with a body mass index of 27 kilograms per meter squared. Physical examination revealed active forward elevation of 130 degrees, external rotation of 35 degrees, and internal rotation to L3 with passive range of motion slightly greater at 140, 40, and L2. Rotator cuff strength was intact at 5 out of 5 in neutral positions, and provocative cuff testing was negative. His baseline American shoulder and elbow surgeon score was 42 out of 100. Imaging confirmed advanced glenohumeral osteoarthritis with Walsh A2 glenoid morphology, preserved bone stock, and intact rotator cuff on MRI. Regarding the surgical procedure and rationale, anatomic total shoulder arthroplasty was selected based on his age, high functional demands, intact rotator cuff, and favorable glenoid morphology, all factors strongly supporting anatomic reconstruction for preserving rotational motion critical for golf. Surgery was performed via deltapectoral approach with subscapularis peel and anatomic repair, modular press-fit humeral stem, and cemented all-polyethylene glenoid component. Intraoperative range of motion demonstrated 160 degrees elevation and 60 degrees external rotation. Let's walk through the rehabilitation progression. In Phase 1, from week 0 to 6, a neutral rotation sling was worn continuously except for exercises. Passive range of motion was limited to 120 degrees elevation and 30 degrees external rotation. Active elevation was strictly prohibited. Physical therapy was conducted twice weekly, focused on passive stretching, pendulum exercises, and scapular retraction. At 6 weeks, passive range of motion measured 115 and 28 degrees, pain was 3 out of 10, and the incision was well healed. Radiographs confirmed stable components, and the patient was cleared for active motion. In Phase 2, from weeks 6 to 12, the sling was discontinued and active-assisted progressing to active range of motion was initiated. External rotation at 90 degrees abduction was permitted to 60 degrees by week 8. Gentle functional internal rotation was introduced in week 10. Periscapular strengthening with 1 to 2 pound weights was emphasized. Stationary cycling resumed at week 6. At 12 weeks, active range of motion was 145, 50 degrees, and T12, The American shoulder and elbow surgeon score was 68 out of 100, and pain was 2 out of 10 at rest. He was cleared for strengthening. In Phase 3, from week 12 onward, progressive resistance training below shoulder level and anterior to the frontal plane was initiated. Closed chain exercises began at week 14. Golf-specific training began at week 16 with gradual progression. Full unrestricted golf was permitted at 6 months. Road cycling resumed at week 12 without restriction. Looking at outcomes and decision points, at 6 months his American shoulder and elbow surgeon score was 82 out of 100, a 40-point improvement exceeding the minimal clinically important difference. Active range of motion was 155, 55, and T12. Visual analog scale pain was 1 out of 10. He returned to pre-injury golf and cycling levels with 90% return to activity and high satisfaction. Critical decisions in this case included selecting anatomic over reverse arthroplasty for his intact cuff and high demands, using a neutral rotation sling for optimized external rotation recovery, maintaining strict subscapularis precautions to protect against the most common complication, and following a 4 to 6 month return to sport timeline based on tissue maturation evidence. Now let's examine case study 2, reverse total shoulder arthroplasty in an elderly patient with rotator cuff arthropathy. A 76-year-old female with massive irreparable rotator cuff tear presented with pseudoparalysis, severe pain rated 8 out of 10 with activity and 6 out of 10 at rest, and complete overhead dependence. Her medical history included type 2 diabetes with hemoglobin A1C of 7.8% and body mass index of 29 kilograms per meter squared with no prior shoulder surgery. Examination revealed active elevation of 60 degrees with passive elevation of 110 degrees, external rotation of 20 degrees, and grade 3 out of 5 deltoid strength with positive lag signs confirming massive cuff insufficiency. Her American shoulder and elbow surgeon score was 18 out of 100. Imaging demonstrated superior humeral migration with acromyohumeral distance less than 5 mm, Walsh E1 glenoid erosion, and massive supraspinatus and infraspinatus tears with Gallier 3 to 4 fatty infiltration rendering the tears irreparable. For the surgical procedure and rationale, reverse total shoulder arthroplasty was selected for her massive irreparable cuff tear arthropathy, pseudoparalysis, and advanced age, all well-established indications for reverse arthroplasty. A lateralized 36 mm glenosphere with 4 mm offset and cemented 135-degree humeral component were implanted. The attenuated subscapularis was not repaired given marginal tissue quality and the inherent reverse prosthesis stability, allowing for accelerated rehabilitation. Intraoperative range of motion was 140 degrees elevation and 30 degrees external rotation. The rehabilitation progression followed an accelerated protocol. From week 0 to 6, sling use was for comfort on day 1 only, with immediate active-assisted and gentle active range of motion in all planes without external or internal rotation restrictions. Enhanced wound surveillance and glycemic monitoring were implemented given her diabetes-related infection risk. Outpatient therapy was conducted twice weekly. Gravity-minimized exercises initially progressed to active elevation. By week 3, she achieved independent active elevation of 90 degrees with pain of 4 out of 10 and a well-healed incision. From week 6 to 12, against gravity exercises were introduced. Resistance training began at week 8 with 1 to 2 pounds, emphasizing high repetition and low load. Functional activities of daily living training was integrated throughout. Dislocation precautions were reviewed, specifically avoiding combined adduction, internal rotation, and extension. By week 10, she achieved independent overhead reaching, dressing, and grooming. She transitioned to a home program at week 12 per the short trial evidence. At 12 months, her outcomes included an American shoulder and elbow surgeon score of 68 out of 100, a 50-point improvement exceeding the minimal clinically important difference and substantial clinical benefit. Active range of motion was 135, 25, and L5. Visual analog scale pain was 2 out of 10. She regained activities of daily living independence and sleep quality with high satisfaction despite limited rotation. Critical decisions in this case included selecting reverse over anatomic arthroplasty for her irreparable cuff and pseudoparalysis, not repairing the subscapularis, which allowed for an accelerated protocol, implementing enhanced surveillance for this diabetic patient, and utilizing a cost-effective home therapy transition supported by the short trial evidence. Finally, let's examine case study 3, revision total shoulder arthroplasty for failed anatomic prosthesis. A 68-year-old male presented 6 years post-anatomic total shoulder arthroplasty with progressive pain rated 7 out of 10 with activity and 5 out of 10 at rest, and functional decline over the past 18 months. His active elevation had declined from 150 degrees at 1 year post-op to 90 degrees currently. His history included remote rotator cuff repair 15 years prior, current smoking at 1 pack per day for 30 years, obesity with body mass index of 32, and well-controlled hypertension. Examination revealed active elevation of 90 degrees with scapular substitution and superior humeral migration. 3 out of 5 deltoid strength, positive hornblower and external rotation-like signs, and intact subscapularis. His American shoulder and elbow surgeon score had declined from 78 at 1 year post-primary surgery to 32 currently. Imaging showed superior humeral migration and glenoid radiolucency greater than 2 mm with superior tilt. MRI confirmed massive irreparable supraspinatus and infraspinatus tears with Goodelier 3 fatty infiltration, glenoid loosening with 15 mm superior bone loss, and intact subscapularis. For the surgical procedure and rationale, revision to reverse total shoulder arthroplasty was recommended for his failed anatomic arthroplasty with secondary rotator cuff insufficiency, glenoid loosening, and bone loss, representing optimal salvage per contemporary evidence. The loose glenoid was removed and the superior defect was treated with morselized autograft from the resected humeral head. A lateralized glenosphere with 10 mm superior augment was implanted. The well-fixed humeral component was retained and only the polyethylene liner was exchanged to preserve bone stock. Final assessment showed stable articulation with 130 degrees elevation and 25 degrees external rotation. The rehabilitation progression followed a conservative protocol. From weeks 0 to 6, the sling was worn for 6 weeks given the revision complexity, bone grafting, obesity, and smoking. Passive range of motion only was permitted, limited to 100 degrees elevation and 20 degrees external rotation. Active elevation and weight-bearing were prohibited. Enhanced wound surveillance was implemented given his obesity and smoking risks. Multimodal analgesia was used while avoiding nonsteroidal anti-inflammatory drugs to support bone graft healing. At week 6, radiographs confirmed stable components with early graft incorporation, and he was cleared for active assisted range of motion. From weeks 6 to 16, gradual mobilization included active assisted range of motion at week 6 and active range of motion not until week 10. Periscapular strengthening began at week 12. Ongoing pain management coordination continued. Strong smoking cessation and weight management counseling were provided. Aerobic conditioning was encouraged. From week 16 onward, progressive strengthening was introduced targeting the deltoid and periscapular muscles. Functional training emphasized activities of daily living independence with realistic goals, not high-level activities. Lifelong activity modifications were counseled. Annual surveillance was recommended. At 12 months, his outcomes included an American shoulder and elbow surgeon score of 58 out of 100. A 26-point improvement meeting the minimal clinically important difference but not substantial clinical benefit. Active range of motion was 115, 20, and L5. Visual analog scale pain was 3 out of 10. He regained basic activities of daily living independence but was unable to reach high shelves or perform extended overhead work. He expressed moderate satisfaction while acknowledging persistent limitations. There were no complications, and radiographs showed stable components with complete graft incorporation. Critical decisions in this case included selecting reverse total shoulder arthroplasty as the optimal salvage for failed anatomic arthroplasty with cuff insufficiency and bone loss, following a conservative protocol appropriate for the revision complexity and risk factors, managing realistic expectations that revision outcomes are inferior to primary procedures but meaningful improvement is still achievable, and recognizing that interdisciplinary collaboration was essential. Now let's integrate these cases and discuss the clinical reasoning they demonstrate. These 3 cases exemplify evidence-based surgical decision-making and rehabilitation individualization across diverse populations. Case 1 demonstrates optimal outcomes with anatomic total shoulder arthroplasty in younger active patients with intact cuffs, achieving high-level recreational return. Case 2 demonstrates reverse total shoulder arthroplasty effectiveness for restoring overhead function in elderly cuff arthropedy patients despite comorbidities, utilizing accelerated protocols, and cost-effective home therapy. Case 3 highlights revision surgery challenges in complex patients, emphasizing that meaningful improvement is achievable though outcomes remain inferior to primary procedures, requiring carefully calibrated expectations. Common themes across all 3 cases include systematic preoperative assessment, evidence-based surgical selection considering age, demands, cuff integrity, and comorbidities. Phased rehabilitation with clear progression criteria, serial validated outcome assessment, and interdisciplinary collaboration. Each case integrates evidence from 2022 through 2025 guiding protocol adaptations that optimize outcomes across diverse shoulder arthroplasty populations. Welcome to the conclusion of this comprehensive course on total shoulder arthroplasty, evidence-based update. Let's begin with a synthesis of what we've covered and its clinical impact. Total shoulder arthroplasty has evolved into a highly successful intervention for restoring function and relieving pain in patients with glenohumeral pathology, with both anatomic and reverse prosthetic designs offering distinct advantages when appropriately matched to patient-specific anatomical, functional, and medical considerations. Throughout this course, we've synthesized the most current evidence from 2022 through 2025, integrating high-quality randomized controlled trials, systematic reviews and meta-analyses, large-scale registry studies, and consensus guidelines from leading professional organizations to provide you with a comprehensive, evidence-informed framework for optimizing outcomes across the diverse spectrum of patients undergoing shoulder arthroplasty. The dramatic expansion of shoulder arthroplasty utilization over the past decade, with projections suggesting continued growth through 2025 and beyond, underscores the critical importance of evidence-based rehabilitation as a determinant of surgical success. While surgical technique and implant design have advanced substantially, the postoperative rehabilitation process remains essential for translating the anatomical reconstruction achieved in the operating room into meaningful functional restoration in patients' lives. As rehabilitation professionals who now understand the biomechanical principles underlying anatomic and reverse arthroplasty, recognize the indications and contraindications for each procedure, implement phased protocols with quantitative progression criteria, identify complications early through systematic assessment, and individualize care for high-risk populations, you are positioned to deliver the highest quality outcomes-oriented care. Let's review several critical principles that emerge from the contemporary evidence base and warrant emphasis as you apply the knowledge gained from this course to your clinical practice. First, patient selection and surgical decision-making. The choice between anatomic and reverse arthroplasty profoundly influences rehabilitation planning, expected outcomes, and complication profiles. Anatomic arthroplasty preserves rotational motion and enables return to high-demand activities in younger patients with intact rotator cuffs, but requires strict subscapularis protection and prolonged rehabilitation timelines. Reverse arthroplasty compensates for rotator cuff deficiency through deltoid recruitment, provides more predictable outcomes in elderly and cuff-deficient populations, and permits accelerated rehabilitation with minimal immobilization in most cases. Understanding these fundamental differences allows you to set appropriate expectations, design individualized protocols, and communicate effectively with surgical colleagues and patients regarding realistic functional goals. Second, evidence-based protocol design. The American Society of Shoulder and Elbow Therapists Consensus Statement for Anatomic Arthroplasty and the emerging evidence supporting accelerated protocols for reverse arthroplasty provide foundational frameworks that should guide rehabilitation planning. For anatomic arthroplasty, the three-phase approach emphasizing 4 to 6 weeks of sling immobilization, passive range of motion within specified limits of 120 degrees elevation and 30 degrees external rotation, delayed active motion until 6 weeks, and progressive strengthening after 12 weeks represents the current standard of care supported by the best available evidence. For reverse arthroplasty without subscapularis repair, immediate active mobilization with minimal or no immobilization is safe, effective, and cost-efficient based on multicenter prospective cohort studies and randomized controlled trials. However, protocol variability remains substantial in clinical practice, and you must balance evidence-based guidelines with surgeon-specific preferences and patient-specific factors requiring individualization. Third, complication vigilance and early identification. While complication rates following contemporary shoulder arthroplasty are relatively low, at 8 to 12% overall, the consequences of missed or delayed diagnosis can be catastrophic. You serve as the front line for detecting complications including subscapularis failure, aseptic loosening, secondary rotator cuff dysfunction, infection, and instability, through systematic clinical assessment, appropriate use of validated outcome measures to identify deviations from expected recovery trajectories, and timely communication with the surgical team when concerns arise. Any patient presenting with acute changes in pain, loss of previously achieved motion or strength, Instability symptoms or constitutional signs concerning for infection warrants immediate evaluation rather than attribution to normal postoperative recovery. The systematic diagnostic approach we presented provides a framework for distinguishing among potential causes of suboptimal outcomes and coordinating appropriate interventions. Fourth, high-risk population management. Patients with diabetes, prior shoulder surgery, rotator cuff pathology, depression and chronic pain, obesity, inflammatory arthritis, and multiple comorbidities require protocol adaptations and intensified clinical management to optimize outcomes and minimize complications. Enhanced wound surveillance and glycemic optimization in diabetic patients, conservative progression with prolonged protection in revision cases, multimodal analgesia and psychological support for patients with depression or chronic pain, and interdisciplinary care coordination for medical optimization represent evidence-based strategies that reduce complication rates and improve functional recovery in high-risk populations. As rehabilitation professionals who recognize comorbidity-specific risks, implement targeted interventions, and maintain close communication with patients' medical providers, you contribute substantially to achieving satisfactory outcomes even in complex patients who historically experienced inferior results. Fifth, patient-centered outcome assessment. Serial evaluation using validated patient-reported outcome measures including the American Shoulder and Elbow Surgeon Score, Western Ontario Osteoarthritis of the Shoulder Index, Disabilities of the Arm, Shoulder, and Hand Questionnaire, and Shoulder Pain and Disability Index is essential for quantifying baseline status, tracking rehabilitation progress, identifying patients not achieving expected milestones, and documenting meaningful clinical improvement. These instruments demonstrate superior responsiveness to change compared to clinician-based assessments alone, capture the patient's perspective on symptoms and functional limitations, and provide objective data that can guide clinical decision-making regarding protocol modifications or need for additional interventions. Establishing realistic expectations based on patient age, comorbidity burden, and surgical complexity, and recognizing that meaningful improvement may not equate to achieving a normal shoulder or complete return to pre-injury activity levels, is critical for patient satisfaction and adherence to rehabilitation programs. Now let's discuss implications for advancing clinical practice. The evidence we've synthesized reveals several areas where current practice demonstrates substantial variability, where research gaps persist, and where opportunities exist for advancing the field through implementation of best practices and continued investigation. First, standardization and dissemination of evidence-based protocols. Despite publication of consensus guidelines by professional organizations, significant variability persists among publicly available rehabilitation protocols for both anatomic and reverse arthroplasty, with many protocols deviating substantially from evidence-based recommendations. Efforts to improve dissemination and implementation of standardized, evidence-based protocols through professional education, collaborative practice networks, and quality improvement initiatives have the potential to reduce unwarranted variation, optimize resource utilization, and improve population-level outcomes. You can contribute to these efforts by adopting consensus guidelines as the foundation for protocol design, engaging in collaborative dialogue with surgical colleagues regarding evidence-based practice, and participating in clinical research and quality improvement initiatives that advance the field. Second, cost-effective care delivery models. The short trial demonstration that home-based rehabilitation achieves outcomes equivalent to formal outpatient physical therapy for reverse arthroplasty patients while reducing care cycle costs by approximately $6,500 per patient has profound implications for healthcare resource allocation and access to care. Identifying patients who can successfully complete home programs versus those who require intensive formal therapy, developing robust home exercise programs with clear instructions and progression criteria, and implementing telehealth or hybrid care models that balance cost-effectiveness with quality outcomes represent important opportunities for optimizing value in shoulder arthroplasty rehabilitation. However, it is critical to recognize that cost reduction should not compromise outcomes, and that some patients, including those with complications, multiple comorbidities, or cognitive or social barriers, will continue to require traditional supervised therapy to achieve optimal functional recovery. Third, personalized medicine and risk stratification. The recognition that patient-related factors including comorbidities, psychosocial variables, and baseline functional status are strong predictors of postoperative outcomes suggests opportunities for developing personalized rehabilitation approaches based on individual risk profiles. Future research should focus on developing and validating risk stratification tools that identify patients at highest risk for complications or poor outcomes, testing targeted interventions for high-risk populations, and evaluating whether personalized rehabilitation approaches improve outcomes compared to one-size-fits-all protocols. You can contribute to this emerging paradigm by systematically collecting patient-reported outcome data, participating in research studies evaluating novel interventions, and advocating for resources necessary to support intensive management of complex patients who require individualized care. Fourth, emerging technologies and innovations. While this course has focused on traditional exercise-based rehabilitation approaches supported by the current evidence base, emerging technologies including wearable sensors for remote monitoring, virtual reality and gaming platforms for engaging exercise programs, blood flow restriction training for enhancing strength gains with reduced loading, and artificial intelligence for predicting outcomes and optimizing protocols hold promise for advancing shoulder arthroplasty rehabilitation. As evidence regarding these innovations accumulates, you should remain current with the literature, critically appraise emerging technologies for safety and efficacy, and selectively incorporate validated innovations that enhance patient engagement, optimize outcomes, or improve access to care. Now let's discuss professional development and lifelong learning. The rapid evolution of shoulder arthroplasty indications, surgical techniques, implant designs, and rehabilitation protocols underscores the importance of lifelong learning and ongoing professional development for rehabilitation professionals who treat these patients. Participation in continuing education programs, engagement with professional organizations including the American Physical Therapy Association and American Occupational Therapy Association, attendance at specialty conferences focused on shoulder and upper extremity rehabilitation, pursuit of advanced certifications in orthopedic or sports physical therapy, and regular review of current literature in high-impact journals are essential strategies for maintaining clinical competence and delivering evidence-based care. Collaboration between rehabilitation professionals and orthopedic surgeons through multidisciplinary conferences, case discussions, joint development of institutional protocols, and participation in quality improvement initiatives enhances communication, fosters mutual understanding of respective roles and expertise, and ultimately improves patient care. Establishing formal or informal mentorship relationships, participating in journal clubs or evidence-based practice groups, and contributing to clinical research through data collection, patient recruitment, or authorship of case reports and case series represent additional opportunities for professional growth and advancement of the field. As we conclude this course, let me offer a final reflection. Total shoulder arthroplasty represents one of the most transformative interventions available for patients suffering from glenohumeral pathology, with the potential to dramatically reduce pain, restore function, and improve quality of life. The success of these procedures depends not only on surgical technique and implant design but critically on evidence-based rehabilitation that protects healing tissues, progressively restores mobility and strength, prevents complications, and enables patients to return to meaningful activities and participation in life roles. As rehabilitation professionals who now understand the biomechanical principles, clinical indications, evidence-based protocols, complication profiles, and individualization strategies presented in this course, you are well equipped to deliver the highest quality care and optimize outcomes for the diverse patients undergoing shoulder arthroplasty. As the field continues to evolve with expanding indications, refinement of surgical techniques, development of novel implant designs, and accumulation of long-term outcomes data, you must remain committed to lifelong learning, critical appraisal of emerging evidence, and implementation of best practices that translate scientific advances into tangible improvements in patients' lives. The journey toward optimal shoulder arthroplasty outcomes is a collaborative endeavor involving surgeons, rehabilitation professionals, nurses, medical providers, and most importantly, the patients themselves who entrust their care to the interdisciplinary team. By embracing evidence-based practice, maintaining vigilance for complications, individualizing care for complex patients, and fostering collaborative relationships across the care continuum, you fulfill your essential role in achieving the ultimate goal: restoring function, reducing pain, and improving quality of life for patients undergoing total shoulder arthroplasty. Thank you for your commitment to advancing your knowledge and expertise in this critical area of rehabilitation practice. Your dedication to evidence-based care will have a direct and lasting impact on the lives of your patients as they navigate their journey through shoulder arthroplasty and work toward restored function and improved quality of life. We will now review the exam questions to solidify your understanding of the key concepts covered in this course on total shoulder arthroplasty. Question 1. Which patient characteristic is an absolute contraindication to anatomic total shoulder arthroplasty? The correct answer is C. Irreparable rotator cuff tear. Rationale. Anatomic total shoulder arthroplasty fundamentally depends on a functioning rotator cuff to provide dynamic stability and control of the humeral head against the glenoid. When the rotator cuff is irreparably torn, the deltoid muscle cannot compensate adequately, leading to superior migration of the humeral head, eccentric glenoid loading, and early component failure. This is precisely why reverse total shoulder arthroplasty was developed, as it allows the deltoid to assume the primary role in shoulder elevation when the rotator cuff is deficient. The other options listed, including age greater than 65, primary glenohumeral osteoarthritis, and Walsh A2 glenoid morphology, are not absolute contraindications and may actually represent appropriate indications for anatomic arthroplasty when combined with an intact rotator cuff. Question 2. In reverse total shoulder arthroplasty, what is the primary biomechanical effect of medializing the center of rotation? The correct answer is B. It increases the deltoid moment arm, allowing the deltoid to compensate for rotator cuff deficiency. Rationale. The genius of the reverse prosthesis design lies in its alteration of the shoulder's biomechanics. By placing the convex glenosphere on the glenoid side and the concave humeral component on the humerus, the center of rotation shifts medially and inferiorly. This medialization increases the lever arm of the deltoid muscle, which means the deltoid can generate greater torque with the same amount of muscle force. This mechanical advantage is critical because patients receiving reverse arthroplasty typically have non-functional rotator cuffs and must rely almost entirely on the deltoid for shoulder elevation. The design does not improve external rotation, which actually remains a common limitation after reverse arthroplasty, and the procedure still often includes subscapularis repair when possible. Question 3. According to the American Society of Shoulder and Elbow Therapists, or ASET, consensus guidelines for anatomic total shoulder arthroplasty, what are the recommended passive range of motion limits during phase 1? The correct answer is A. Passive elevation to 120 degrees and external rotation to 30 degrees. Rationale. These specific motion limits represent a careful balance between two competing rehabilitation goals. On one hand, early motion is essential to prevent adhesive capsulitis, which can significantly compromise outcomes after shoulder arthroplasty. On the other hand, the subscapularis tendon, which is detached during the surgical approach, requires protection during healing. Limiting external rotation to 30 degrees prevents excessive tension on the subscapularis repair, while allowing elevation to 120 degrees maintains glenohumeral mobility and prevents capsular adhesions. More aggressive motion parameters, such as 150 degrees of elevation or 60 degrees of external rotation, would place unacceptable stress on the healing subscapularis, while more conservative limits could predispose the patient to stiffness. Question 4. For patients with diabetes undergoing shoulder arthroplasty, what is the most critical rehabilitation protocol modification? The correct answer is D. Enhanced wound surveillance and individualized progression based on healing status. Rationale. Diabetes mellitus creates several challenges in surgical recovery, including impaired wound healing, increased infection risk, and potential for delayed tissue repair. Rather than applying arbitrary restrictions like delaying all rehabilitation or eliminating strengthening exercises, the evidence supports a more nuanced approach. Clinicians should monitor wounds more frequently, watch carefully for signs of infection or dehiscence, and progress the rehabilitation protocol based on how the individual patient is actually healing rather than following rigid time-based milestones. This patient-centered approach allows those who heal well to progress normally while providing additional protection for those experiencing healing complications. Glycemic control before and after surgery also plays a critical role in optimizing outcomes for this population. Question 5. Which clinical examination finding is most suggestive of subscapularis insufficiency following anatomic total shoulder arthroplasty? The correct answer is B. Positive belly press test. Rationale. The subscapularis is the primary internal rotator of the shoulder and plays a crucial role in anterior stability. Following anatomic total shoulder arthroplasty, subscapularis integrity is particularly important because the tendon is detached and repaired during the surgical approach. The belly press test, along with the lift-off test and bear hug test, specifically assesses subscapularis function by requiring the patient to generate internal rotation force. A positive belly press test, where the patient cannot maintain pressure against the abdomen without wrist flexion and elbow extension, indicates subscapularis weakness or rupture. The drop arm test and MT-CAN test evaluate the supraspinatus, while the near impingement sign assesses for subacromial impingement, making these tests less relevant for detecting subscapularis insufficiency. Question 6. According to the evidence comparing anatomic and reverse total shoulder arthroplasty outcomes in patients with intact rotator cuffs, which statement is accurate? The correct answer is C. Anatomic arthroplasty provides better restoration of external rotation with differences of 15 to 25 degrees. When the rotator cuff is intact, anatomic total shoulder arthroplasty preserves more physiologic shoulder mechanics compared to reverse arthroplasty. The research consistently demonstrates that patients with intact rotator cuffs achieve substantially better external and internal rotation with anatomic prostheses. The 15 to 25 degree advantage in external rotation represents a clinically meaningful difference that affects activities of daily living, particularly those requiring hand positioning behind the head or behind the back. This rotational advantage is especially important for younger, active patients who wish to return to sports or occupational demands requiring full shoulder motion. While reverse arthroplasty excels in patients with rotator cuff deficiency, it sacrifices rotational motion due to its constrained design and altered biomechanics. Question 7. A 58-year-old recreational golfer presents with primary glenohumeral osteoarthritis, an intact rotator cuff confirmed on MRI, and adequate glenoid bone stock. Which surgical approach is most appropriate to maximize return to sport participation? The correct answer is A. Anatomic total shoulder arthroplasty. Rationale. This clinical scenario presents an ideal candidate for anatomic total shoulder arthroplasty. The patient has the three key prerequisites: primary glenohumeral osteoarthritis as the underlying diagnosis, a confirmed intact rotator cuff, and sufficient glenoid bone stock to support component fixation. At 58 years old with recreational athletic goals, preserving maximal rotational motion is critical for returning to golf, which demands significant shoulder rotation during the swing. Anatomic arthroplasty will provide superior external and internal rotation compared to reverse arthroplasty, translating directly to improved sports performance. Reverse arthroplasty would sacrifice rotational motion unnecessarily given the intact rotator cuff. Hemiarthroplasty has largely fallen out of favor due to inferior long-term outcomes from glenoid erosion, and arthroscopic debridement would not adequately address the underlying joint destruction. This concludes our exam review. Remember that understanding the rationale behind each answer will serve you well not only on the examination but also in your clinical practice when caring for patients undergoing shoulder arthroplasty.